Let's discuss the cardiovascular physiology. In first topic is the stroke volume. So stroke volume is basically the amount of blood which is ejected by the left ventricle per beat or per stroke. All right. So its the stroke volume will be affected by three things: the contractility, the afterload, and the preload. If you increase the contractility, you are basically increasing the stroke volume. If you increase the preload or the blood coming to the left ventricle, you are increasing the stroke volume. But if you increase the afterload, the resistance on the left ventricle, then you are decreasing the stroke volume. So these three relations are very important. Increased contractility, the example is the stress, anxiety, exercise. Okay, in these conditions, catecholamines release and it will increase the force of contraction of the left ventricle. Example of the increased preload is the pregnancy. Pregnancy is physiologically it's a high volume condition. The blood volume is increased, so that's why the stroke volume is increased in pregnancy. Similarly, if you decrease the afterload, okay, then it will increase the stroke volume. So the relation is basically inverse. A failing heart has decreased stroke volume, mean it can be systolic dysfunction and or diastolic dysfunction. All right, but remember, in systolic dysfunction, the stroke volume is decreased, and in diastolic dysfunction, both. So in failing heart, mean it can be a systolic heart failure or it can be diastolic heart failure. But in both of these conditions, the stroke volume is reduced. Another important thing is the contractility. Remember, contractility is basically the intrinsic ability of the heart muscle to contract with the force. So it is independent of the preload or the afterload. It means that it's how strong the left ventricular muscle contract to eject the blood from the left ventricle. So if you increase the contractility, you are increasing the stroke volume. And how contractility increase? It's by catecholamines, okay? Like the epinephrine, norepinephrine, these are the catecholamines. So the catecholamines basically, what it will do, it acts on the beta-1 receptor. Beta-1 receptor or the heart, heart is one, lungs are two. So beta-1 is on the heart and beta-2 is on the lungs. Just remember, when you stimulate the beta-1 receptor, you are activating the protein kinase A. The protein kinase A will do what? It will phospholambin phosphorylation. It will cause the phospholambin phosphorylation, and that will lead to the it will activate the calcium ATPase. So overall, the calcium will be increased within the storage site in the sarcoplasmic reticulum. Now, the activated protein kinase A, it will causes the calcium channel phosphorylation, and it will increase the calcium entry, and that will lead to the increased calcium induced calcium release. So overall, what we will be having, like by stimulating the beta-1 receptor, we are activating the intracellular calcium. Now remember, the one or two line answer for this, like when the catecholamine stimulates the beta-1 receptor, the G stimulatory protein will activate. It will cause the increased cyclohydroxy monophosphate. The CAMP level will increase. Then the protein kinase A will cause the phosphorylation of the L-type calcium channels and phospholambin, and that will increase the intracellular calcium. After that, this calcium will be stored within the sarcoplasmic reticulum, so the storage site will be having more calcium. And then that storage site, when you increase the calcium in the storage site, the upcoming beat will be stronger, like the force of contraction will be stronger, and the relaxation will be faster. So this is the basic phenomena. And the another thing is that in this, like the sympathomimetic drugs, remember the dopamine, dobutamine, epinephrine, norepinephrine, these are the sympathomimetic drugs that increase the sympathetic activity. So all of these drugs are basically increasing the cardiac output. You can see the stroke volume, and these drugs basically stimulate this beta-1 receptor by this whole mechanism. Okay, so dopamine, dobutamine, epinephrine, norepinephrine, all these will increase the conductivity by this mechanism, by increasing the protein kinase A, and further we discuss this. So and now remember digoxin. The digoxin is doing what? It basically blocks the sodium potassium channel, so it indirectly inhibiting the sodium calcium exchanger. How? When you block the sodium potassium exchanger, you are increasing like the sodium within the cell, and you are, when you increase like normally what happen is that the sodium calcium exchanger exchange the sodium uh, with the calcium. So if you block the sodium potassium channel, you are increasing the sodium within the cell. The cell will not shift the sodium out of the sodium potassium channel. If you block it, then the sodium will not be moving out of the cell. So this sodium, which is within the cell, as a result of that, the sodium calcium channel will be blocked. It will not be working. So when you block the sodium calcium channel, the calcium within the cell will be high, and that will lead to the increased force of contraction or increased contractility when you give someone digoxin. This is the mechanism. Now, the contractility is basically, or the stroke volume is decreased with the beta 1 blocker because the camp level will be low. Heart failure, we discussed this, that especially the stroke volume is decreased both in the systolic and diastolic dysfunction. But here they mentioned that the contractility is decreased in the systolic dysfunction. Acidosis, in acidosis, the catecholamines not work, or their receptors. So the sensitivity of the catecholamines are decreased, and the force of contraction will be low. So, and in hypoxia, hypercapnia, obviously, when you decrease the oxygen supply to the heart, or you increase the CO2 level, so that will also cause the decreased contractility. Non-dihydropyridine calcium channel blocker will also cause this decreased contractility. So these are some conditions that reduces the contractility. Moving towards the preload, remember, the preload is basically it's the amount of blood that is loaded into the left ventricle, and it basically shows how much stretch is on the fibers prior to contraction of the left ventricle. So if you increase the preload, you are increasing the cardiac output. More preload means more work the heart must do to, and will increase the oxygen requirement as well. So here we can say that if you increase the blood flow towards the left ventricle, then the left ventricle will eject this blood more. So preload is approximated by the ventricular and diastolic volume, and it depends on the venous tone and circulating blood volume. Mean, if the venous tone is more, then the vein are the reservoir of the blood. So if you increase the venous tone, more blood will be coming towards the heart, and it will be ejected by the left ventricle more. So one thing is that the increased venous tone. The second thing is the blood volume. Overall, if you increase the blood volume, you are increasing the preload. The example of the increased circulating blood volume is the pregnancy, or if you like give someone intravenous fluid. Again, the vasodilator like the nitroglycerin, it decrease the preload. So these are the vasodilators. So the preload will decrease by the nitroglycerin. The afterload is basically the resistance on the left ventricle. If you increase the afterload, you are decreasing the stroke volume. And remember, the afterload is approximated by the mean arterial pressure. One important thing is that to here, I would like to add one thing in the preloads. I want to complete this as a whole. So if you to decrease the preload, either you will remove the blood from the person, like in a bleeding situation, in trauma, or in dehydration, the preload is decreased because the volume of blood is lost. And in case of the increased heart rate, so if you increase the heart rate, the cardiac output is increased, but after certain to certain limit. Okay, if you increase the heart rate much more, then the amount of blood coming to the left ventricle will be low, because the heart will be beating fast, fast, fast. The diastolic phase time will be low. That's why the preload will be low and the cardiac output will be low. So, or if you like, if you want to decrease the preload, the third thing, first we mentioned about the remove the volume, or you can say trauma, bleeding. Second, you can increase the heart rate, uh, and third is the pool of blood in the vein, means the nitroglycerin. If you give someone nitroglycerin, it will dilate the vein, and the blood will be within the vein. Now, to the left ventricular end diastolic volume is basically the volume of the blood in the ventricle when at the end of the diastole. Okay, this is the left ventricular end diastolic volume, as they mention it. All right. Now, moving towards the afterload. Afterload is basically it's the forces that will resist the flow out of the left ventricle, or the amount of resistance the left side of the heart has to overcome in order to eject the blood. Or in a layman term, you can say it's the resistance over the left ventricle. So a heart must squeeze to increase the pressure, and it needs to open the the aortic valve, push the blood into the aorta, and this is harder to do if blood pressure is high. If the aortic valve is stiff, or if something in the way like hypertrophic obstructive cardiomyopathy or subaortic membrane mean, remember there are certain conditions, okay, where the afterload is high. If you increase the blood pressure, mean you are decreasing the size of the pipes, you are stiffening the vessels. So this stiffening of the vessels will increase the peripheral resistance. So basically, if you think like that, the pipe size is smaller, so the pressure over the left ventricle will be more, the resistance for the left ventricle will be more. The left ventricle, it will be harder for the left ventricle to push the blood against the small or narrow vessels. So in hypertension, what happened is the resistance or the left ventricle increase. Also, in the aortic stenosis, the valve stenosis, so the resistance or the left ventricle is more. In the hypertrophic obstructive cardiomyopathy, the left ventricular outflow tract, the muscle size will be more. So the flow of blood ejected from the left ventricle to the aorta will be low. And in you can say in the so these are the in subaortic membrane. So these are the conditions where the afterload is increased. So to increase the afterload, the raise mean blood pressure, obstruct the outflow of the left ventricle. So these are the either you will like increase the mean arterial pressure, or you will constrict the aortic valve or the outflow tract. To decrease the afterload, you will be lowering the mean blood pressure. You will treat the aortic valve disease, like if there is aortic stenosis, you will go for aortic valve replacement. Or in case of the hypertrophic obstructive cardiomyopathy, will remove that extra portion of the muscles, the more surgery or more operation. Now, preload is basically how much the heart fills up, and afterload is how hard it has to push to get the blood moving. Okay. Moving towards the uh, certain medication, all right, and this law of Laplace, I would like to discuss this as well. So after afterload is approximated by the mean arterial pressure, increase wall tension per Laplace law, increase pressure, increase afterload. How? Let me show you some diagram. I hope that, yeah, this is the diagram. So according to the law of Laplace, uh, this is the normal heart. Okay, this is the left ventricle, this is the right ventricle. What happened is, in case of the pressure overload. We have two conditions. Either it's a pressure overload, either it's a volume overload. You want to increase the pressure on the left ventricle. Either you will increase the afterload by increasing the blood pressure, or you will increase the volume or preload to the left ventricle. For example, in case of blood pressure increase, like if someone is having hypertension, if someone is having aortic stenosis, if someone is having hypertrophic obstructive cardiomyopathy or subaortic membrane, in all these conditions, the pressure over the left ventricle will be more. So the sarcomere will be in parallel addition. So in the left ventricle, the muscle mass will increase, and when you increase the muscle mass in the left ventricle due to the pressure overload, then the sarcomere addition will be in parallel. And so how this basically occurs? By increasing the pressure in the left ventricle by hypertension, aortic stenosis, you are causing the pressure overload. Okay, so that will lead to concentric hypertrophy. How? Pressure overload, chronic increased pressure in the ventricle. Okay, the sarcomere will be added in parallel, the left ventricular mass is increased, the wall of the left ventricle becomes thickened, and classic causes we already discussed, like hypertension, aortic stenosis, hypertrophic obstructive cardiomyopathy, all these conditions. So the compliance of the left ventricle will be decreased. The left ventricle distensibility or the relaxation will be decreased, and that will lead to the diastolic dysfunction. Mean, diastole the heart becomes relaxed. So if the wall of the muscles of the left ventricle becomes more thickened, then the size of the left ventricle becomes small. Here you can see the cavity size of the left ventricle is too small. So the filling of the left ventricle will not be occur during diastole properly, and that will lead to diastolic dysfunction. Opposite to that, in case of the regurgitation, where the volume of the left ventricle increases, that can be because of the aortic regurgitation, that can be because of the mitral regurgitation, it can be because of the heart failure due to ischemic heart disease and dilated cardiomyopathy. So in all these conditions, the volume in the left ventricle will be more. There will be more blood within the left ventricle. So these increased volume overload will lead to the addition of the sarcomere in series. Okay, here it's parallel, here it's series. So this addition of sarcomere in series will lead to the eccentric hypertrophy. Okay, and is more. Or will be added in series. The left ventricular mass is increased, the wall thickness is not increased, and is seen in volume overload condition like in aortic regurgitation, mitral regurgitation, in cardiomyopathy like ischemic cardiomyopathy, okay, or non-ischemic cardiomyopathy. So this was one of the diagrams that that was for the law of Laplace, okay. Let's move back to the topic, and so moving towards the cardiac oxygen demand. Here we also like to discuss that the LV compensate for increased afterload by thickening hypertrophy in order to decrease the wall stress. This is basically the same law of Laplace. If you increase the afterload, you are increasing the pressure within the ventricle, left ventricle. That pressure will cause the increased tension or the left ventricular wall, and in order to compensate this, the LV will increase its muscle mass. Okay, that we call this hypertrophy. So when you in order to to decrease the wall stress, the LV will go into hypertrophy. Now, what are the medications that can decrease all these afterloads? So if you give someone hydralazine, it's basically a medication to decrease the afterloads given in the hypertension. So these are the arterial vasodilator. So you are decreasing the afterload by hydralazine. AA is afterload is basically is doing what? You are decreasing the afterload by arterial vasodilator. AC inhibitor and ARBs is both decrease the preload and afterload. It's important that AC inhibitor is famous for decreasing the preload and afterload both. Chronic hypertension will increase the mean arterial pressure and the left ventricle will go into hypertrophy. Moving towards the cardiac oxygen demand, myocardial oxygen demand is increased by conductivity. We already discussed this. Force of contraction is increasing myocardial oxygen demand. Increasing the afterload will increase the pressure of the left ventricle. The left ventricle has to eject the blood. It will need more work, more energy, more oxygen to eject the blood against the stiffened vessels. So the afterload increase will increase oxygen demand. If you increase the heart rate, again you are increasing the load over the heart. You are increasing the oxygen demand of the heart. If you increase the diameter of the left ventricle, you are increasing the wall tension and you are increasing the oxygen demand. So any condition where you are putting more work over the heart, we are the oxygen demand. Why this condition where the oxygen where the heart is in stress, like the blood flow to the heart is low and the demand is high? If you take the example of the coronary artery obstruction, the myocardial infarction, where the coronary vessel size is small due to thrombus. So that occlusion or thrombus is doing what? It is decreasing the blood flow to the heart. So the heart is in stress now. What we will be doing, you need to decrease the stress over the heart in order to decrease the oxygen consumption. So what we will do, we will decrease the heart rate by beta blocker. Okay, so this concept is important in the scenarios where the heart is in stress and the demand of oxygen is more. So you need to know that how you can decrease the demand of oxygen. Now the coronary sinus basically it's contain the most deoxygenated blood within the body. Okay, because all the oxygen contraction, the oxygen extraction organ wise is higher for heart. So if you extract more oxygen from the blood, you are basically deoxygenating the blood. So the highest amount of deoxygenated blood is within this coronary sinus, okay, which is draining into the right atrium. Wall tension follows the Laplace law. We already discussed this. If you increase the wall tension, you are increasing the pressure, and so basically, this is actually the scenario where the relation of the radius and pressure and wall tension. Okay, so simply the it's like it's the if you look at if you decrease the cavity size, okay, if you reduce the radius of the cavity, you are basically uh, improving the if you reduce the radius, if you reduce the cavity size, you are increasing the pressure, okay, and the wall tension. So wall stress is basically inversely proportional to the wall thickness and directly proportional to the pressure and radius. So as per the Laplace law, we already, I think, discussed this in the eccentric and concentric hypertrophy. Okay. Now, moving towards the cardiac output equations. So the cardiac output equation is basically the stroke volume is equal to the end diastolic volume minus the end systolic mean, the amount of blood ejected by the left ventricle in the one beat or in one stroke. How? When the blood is coming to the heart and the heart becomes fully relaxed, when the heart is fully relaxed, at the end of diastole or at the end of this relaxation, the amount of blood within the left ventricle, we call it the left ventricle end diastolic volume. Now, when the heart is ejected, the systole occurs, and at the end of the systole, the amount of blood within the left ventricle, we call this end systolic volume. So when you minus the end systolic volume from the end diastolic volume. That will give you the stroke volume. Mean normally 110 to 120 is the end diastolic volume, and 40 to 50 is the end systolic volume. So minus it, you will be having like 70 ml of almost stroke volume in a normal person. Ejection is it's the stroke volume, or you can say the amount of blood ejected by the left ventricle divided by the total amount of blood at the end of diastole. Okay, so stroke volume divided by end diastolic volume will give you the ejection fraction. Or stroke volume, we know it's the end diastolic volume minus the end systolic volume divided by. So this is divided by end diastolic volume. So this formula is important. Ejection fraction is the index of the ventricular contractility, and it decreases in the systolic heart failure. Usually, normal and diastolic heart failure mean ejection fraction if you causes the uh, problem regarding the ventricular contractility, you are causing the decrease in the stroke ejection fraction. In ischemic heart disease, what happened? The blood flow to the heart is low. The left ventricular muscles become die, or you can say myocardial infarction. So the infarcted muscle will not generate the force of contraction or contractility. So that's why the ejection fraction will be low. So one of the example is they mentioned here is the decrease in the systolic heart failure. And the EF is decreased in the systolic heart failure, usually normal and diastolic heart failure. Cardiac output is the, according to the the simple formula is, we know that it's the stroke volume and heart rate. And by fixed principle, it is the rate of oxygen consumption by arterial O2 content minus the venous O2 content. So in the early stage of the exercise, the cardiac output is maintained by increased heart rate and increased stroke volume. In the later stages, it is only the, you can say it is only the heart rate that is maintaining the stroke volume or cardiac output. So the important thing here is that this equation is basically showing that the cardiac output, stroke volume, heart rate. Initially, heart rate increase in the during exercise, stroke volume increase. But later on, the stroke volume will become like fixed. It is constant, but the heart rate is basically remain increased, and it is the heart rate that is deciding to improve to maintain the cardiac output. So diastole is shortened with increased heart rate. Remember, when the blood is coming to the heart, it is ejecting more blood from the left ventricle or from the heart. So during diastole, if you increase the heart rate, what if you increase the heart rate? The diastolic filling time of the left ventricle will be reduced. So the amount of blood ejected will be, low. The cardiac output will be low. So this concept is important in condition where there is pathological increase in heart rate, like atrial fibrillation. So what happened is that diastole is shortened with increased heart rate, with very much increased heart rate. Ventricular tachycardia, for example, that will lead to decreased diastolic filling time, and that will lead to decreased preload, and so decreased stroke volume and decreased cardiac output. So uh, this concept is important regarding that pathological increase in the heart rate. Now moving towards pulse pressure, and in the pulse pressure, one important thing is that, remember, the cardiac output is if someone is having increased body size, the oxygen consumption will be high. Okay, if the arterial O2 content, like oxygen saturation, we know the oxygen saturation from the finger probe. Okay, we know the oxygen saturation when we put the finger probe, and we know that. Okay. But for venous oxygen content, we know it by Swan-Ganz catheter. Okay, here the arterial oxygen content is by, we know it by what? Finger probe. Venous is by Swan-Ganz catheter. Now the pulse pressure is basically, it's the difference between the systolic blood pressure and diastolic blood pressure. For example, if someone is having 120 by 80 of the systolic by diastolic blood pressure, so we said that the pulse pressure is 40. How? 120 minus 80 is 40. So one simple way to know the pulse pressure is this. And there are certain conditions, okay, where the pulse pressure is like uh, increase or decrease in certain condition. The important thing is to know that if you stiffen the aorta, you are decreasing the distensibility or relaxation of the aorta, and you are increasing the pulse pressure. How? Remember, the pulse pressure is directly proportional to the stroke volume and inversely proportional to the arterial compliance. This formula is important. And when you stiffen the aorta, you are basically decreasing the aortic arterial compliance. So when you decrease the aortic arterial compliance, you will be increasing the pulse pressure. Now I'll be giving you the example, but just remember, also the arterial compliance is reduced with the aging. Now the aorta becomes stiffened when the person aged. So stiffening of the aorta means reduce the compliance and increasing pulse pressure. You what actually in old age, the loss of elastic fibers within the aorta becomes less stretchy and less distensible, and so it will be stiffened, it will be hard. So the compliance will be low and pulse pressure will be high. So pulse pressure is directly proportional to the stroke volume and inversely proportional to the arterial compliance. Increase in pulse pressure, like in hyperthyroidism, okay, in the aortic regurgitation, in the aortic stiffening, obstructive sleep apnea, anemia, exercise. So actually, these are the conditions where you are increasing the like you are in the pulse the diastolic blood pressure will be low basically in these conditions. So we know that, let's say if someone is having um, aortic regurgitation and his systolic blood pressure is 120 and the diastolic blood pressure, which is not in a normal person, 80, but in the aortic regurgitation it will goes down, it will be like 50 or you can say 60. So previously the pulse pressure was 40 in a normal person, but here in aortic regurgitation, when you reduce the diastolic blood pressure, 120 minus 50, let's say it will be 70. So the pulse pressure will be 70. So one example was aortic regurgitation. In aortic stiffening, again, it is like causing the increase in systolic blood pressure. In hypertension, what happened? The systolic blood pressure is 170, 160, and diastolic blood pressure is 90 or 80. So again, the pulse pressure will be high. You are stiffening the aorta, you are increasing the systolic. So it is either the increase in systolic blood pressure or decrease in diastolic blood pressure that is causing the increase in pulse pressure. Moving towards the decrease in pulse pressure, this the example is aortic stenosis. In aortic stenosis, what happens is that systolic blood pressure is low. In cardiogenic shock, systolic blood pressure is low. In cardiac tamponade, systolic blood pressure is low. Advanced heart failure, conductivity is low, systolic blood pressure is low. So in these are the conditions where the pulse pressure is low. Where there is, remember, the cardiogenic shock, the heart failure, these are the conditions where there is failure of the conductivity of the left ventricle. Left ventricle is not ejecting the systolic volume. Mean arterial pressure is basically the cardiac output. And remember, one important thing is here, systolic blood pressure is determined by the stroke volume, while the diastolic blood pressure is determined by the total peripheral resistance. This is also important. Note this concept. So, uh, mean arterial pressure is the cardiac output and total peripheral resistance. And mean arterial pressure is, you can say, is the two-thirds of the diastolic blood pressure plus one-third of the systolic blood pressure. Uh, Basically, this mean arterial pressure is the pressure on which our organs are perfused. If you said that your systolic blood pressure, what is important between the systolic blood pressure, diastolic blood pressure, or mean arterial pressure? I'll say the mean arterial pressure is important. And it must be above 60. Why? Because it is the perfusion pressure, okay? It is the pressure on which the organs are perfused. I'm moving towards the Starling curves. Starling curves, as you can see here, they are First of all, this is the stroke volume, and this is the ventricular preload or ventricular end diastolic volume. Normally, we said that if the preload is increased, the stroke volume is increased, but up to certain limit. Okay. After that, if you are increasing the preload, the stroke volume will not be increased. It will be something like become constant. Normally, as you can see here, in the resting condition, if you give me IV fluid or if you give someone like blood, okay, so you are increasing the left ventricular end diastolic volume. So the amount of blood coming to the left ventricle is increase, and it will eject, like the left ventricle will eject more volume, up to certain extent. Okay, then it becomes constant. Now, in a normal person who is doing exercise, you can see here, increasing the end diastolic volume is increasing the stroke volume. Okay, so for a running man, he needs more blood. He needs more stroke volume. So what happened is that the return to the heart will be more, the preload will be more, and the heart will be ejecting more stroke volume. Now moving towards the person who is in heart failure but is taking inotropic support. So here you are increasing the left ventricular end diastolic volume, and the stroke volume is increase. But it is not that much increase compared to the normal person. But a person who is in heart failure and is not taking any inotropic support, and if you give him the stroke, volume, or you can say if you increase his end diastolic volume or preload, it will increase the stroke volume, but not that much. Okay, it will be fixed after a small period of time. So this concept is important. Remember, in a heart failure, we give fluid very cautiously because we know that if we give the patient fluid, his left ventricle is failed. It's not contracting properly. The muscle is not contracting properly. So the volume that we'll be giving will not be properly ejecting. So we will like worse the heart failure. That's why we'll be cautious in giving the fluid to the heart failure patient. So force of contraction is proportional to the end diastolic length of the cardiac muscle fiber or the sarcomere length. The more is the sarcomere length or the muscle fiber stretch, the more it will contract. Okay. If you give volume to someone, what you are doing, you are increasing the left ventricular muscle mass stretch. The sarcomere length is increasing, and it will be contracting back forcefully. So stroke volume will increase contractility with catecholamines like positive inotropy, dobutamine, mineralone, digoxin, also increasing the stroke volume. It decreased contractility with the loss of the function myocardium, like in myocardial infarction, leading to heart failure, beta blockers, acutely especially, or non-dihydropyridine calcium channel blockers, or in heart failure. So, are in these conditions the contractility is low. These are the like the Starling curves, and it's the relation between these two, stroke volume and ventricular end diastolic volume. Now, moving towards the resistance and the pressure flow. Let's discuss this resistant pressure flow, and I would like to discuss here first the Poiseuille's law. If you look at these two vessels, okay, this and this one, so just remember the rule is that if you double the radius, you multiplies the flow rate by 16%. For a patient, why this concept is important? For a patient who requiring a rapid blood transfusion, the shortest possible catheter with the widest possible diameter, for example, large bore peripheral eye intravenous catheter should be selected. This means, let's say this is a cannula size, okay, small cannula size, and this is another cannula size, okay. So in case of blood loss or a trauma patient, we need a wider radius diameter. We need a wider diameter cannula and a short length. These two things are important. Why? Because doubling the length doubles the resistance, and that resulting in a half the flow. So if you put a wider and shorter length cannula, good, flow will be good. Maximum blood will be moving to the patient uh, fastly. Compare if you keep the resistance, if you keep the length of the cannula higher, then the flow will be reduced by 50%. So this means to achieve the equivalent flow of doubling the diameter, the length will be shortened to 1 by 16 of the original. So for this reason, we keep the catheter short to 1/16 of the original length. Remember, in a simple term, okay, according to this rule, doubling the radius multiplies the flow rate by 16%. Okay, these are all the detailed diagram. I'm just discussing the important thing that if you double the diameter of cannula, you are increasing the flow by 16%. And also remember the relation of the length. Okay, so if the radius, length, and pressures are kept constant, placing a second identical catheter would result in double the flow. So to achieve the equivalent flow of doubling the radius, an additional 15 catheters will be need to be inserted. So for this reason, a few, you can say, low resistance intravenous access sites and two large bore peripheral intravenous catheters are preferable to many high resistance sites. I will just keep it simple and shortened. In case of trauma, gives the patient wide bore and short length cannula. Remember this, okay? This is the rule, and this is Poiseuille's law. So now, if you look at this resistance pressure flow, the volume is basically the flow velocity and cross-section area. It simply means that if a cross-sectional area of a vessel is large, the flow velocity will be low, and the example is the capillaries. Okay, in capillaries, capillaries have a highest total cross-section areas and the lowest flow velocity. Now moving towards this equation of resistance. So basically, resistance is equal to driving pressure is the change in pressure, okay, that keeps the flow of blood going on. And so basically, the this viscosity, okay, this N, viscosity is the how thickened the blood is. So if the blood is more thickened, like in polycythemia, in hyperproteinemia, the resistance will be more. If the length is more, resistance will be more. Okay. If the if you increase the radius or if you double the radius, you are increasing the or you are decreasing the resistance by 16%. Just remember this. So here you can see this resistance of vessels in series versus resistance of vessels in parallel. In series, the change in radius will cause huge change in the resistance. Okay, in human being, in us, the total resistance of vessels are in parallel, or organs are in such a way that the flow in parallel. So uh, human organs are arranged in parallel. Okay, and the resistance is low. Here you can see is that they mentioned the same concept that we discussed. The capillaries have the highest total cross-section area and lowest flow velocity. Pressure gradient drives the flow from high pressure to low pressure. It is the pressure difference that keeps the flow going, the blood going on to move from area to another area. So arterioles account for the most of the total peripheral resistance. Very important that it is the arterioles that's maintaining the blood pressure or peripheral vascular resistance. Veins provides most of the blood storage capacities. It's almost 60 to 70%. Viscosity depends on hematocrit. The more viscous the blood is, the more hematocrit it will be having. Viscosity increase in the hyperproteinemic states like multiple myeloma, polycythemia, and viscosity is decreased in anemia. So these are some of the conditions, by example, they show it. Now moving to this cardiac and vascular function curve. Remember, we discussed this stroke volume, and we said that it depends on the stroke volume, depends on contractility, depends on the volume status of the heart or preload, and the you can say the afterload. So remember, the inotropy and contractility are closely related and often used interchangeably. And inotropy usually refers specifically to the force of myocardial contraction. Okay, the force of contraction of the left ventricle. So if you look at this uh, vascular, cardiac and vascular function curve, uh, here the first thing is the inotropy. Okay, so normally this is the cardiac function curve, the venous return, right atrial pressure. Now, what happened is that, let's say, if you give someone inotropic drugs that increase the force of contraction, which means you are giving catecholamines to someone, okay? Epinephrine, etc., dobutamine, milrinone, um, or if someone is doing exercise or taking dioxin. So, in all these conditions, what happened is that you are increasing the force of contraction and you are increasing the cardiac output. So, the cardiac from normal person, the cardiac output increase in case of these conditions. Now, what happened if someone is having heart failure or if someone is taking the negative uh, inotropic you can say the beta blocker, or someone is taking narcotic overdose. So in this condition, the cardiac output will be low. Now the cardiac output is decreasing, and the right atrial pressure is also increasing. If you uh, eject the blood from the left ventricle, okay, the backward flow of blood will be low, so the right atrial pressure will be low. Now, if you increase the like if you decrease the ejection of blood from the left ventricle, the backward flow will be more and the right atrial pressure will be more. So that's why by increasing the cardiac output, the right atrial pressure is reducing, but by decreasing the cardiac output, okay, from here to here, the cardiac output is also decreasing, the right atrial pressure is increasing. Now, moving towards uh, here they clearly mention is that the change in contractility altered the stroke volume, and it will alter the cardiac output and the venous return and the right atrial pressure. So these are some of the condition where this. Now let's move to the second one. Okay, if here normally this is the cardiac output and the right atrial pressure is here. So if you give someone intravenous fluid, normal saline, blood transfusion, you are increasing the preload and you are increasing the cardiac output. At the same time, you are increasing the right atrial pressure, because whatever you give to the vein, the blood is going through the from the vein, it will be going through the either IVC or SVC into the right atrium. So the right atrial pressure, by giving the volume, it will increase, and that blood is coming to the left ventricle and it will be ejecting from the left ventricle. Like increasing the preload is increasing the cardiac output. Simple rule. Now, if someone is bleeding, okay, then the volume coming to the right atrium is decreased and right atrial pressure is decreasing, and more blood is also the preload is decreasing and cardiac output is decreasing. It's a simple concept. Here you can see that the peripheral resistance, okay, if you are increasing the afterload, Let's say this was the normal person, okay? Cardiac output, right atrial pressure. You increase, if you give someone, you can say vasopressors. So what you are doing, you are increasing the afterload. So by increasing the afterload, you are decreasing the cardiac output. Why? Because the left ventricle pressure or the left ventricle will be more, so it will eject the blood, but with the resistance. So the flow, the blood moving out of the ventricle will be decreasing. Normal, increased peripheral resistance. Here the important thing is that the right atrial pressure is almost the same, and if you decrease the total peripheral resistance, okay, by giving someone, in exercise or in arterial venous shunt, AV shunt, or if someone is doing exercise, so the afterload is, or you can say the total peripheral resistance is decreased. So that's why the cardiac output is improved in exercise or in AV shunt. Here, the important example is if you give someone fluid infusion, sympathetic activity, arteriovenous shunt, and all these conditions, volume and the cardiac output and the right atrial pressure both increase. So, and here another example is that venous return is the like in acute hemorrhage, or you can say in spinal anesthesia, the blood returning to the heart is reduced and the cardiac output is reduced. So basically, the blood is pooled in the vasculature in case of spinal anesthesia. So overall, this was some of the changes that occurs. Uh, yeah, here I mentioned that changes often occurs in tandem and may be reinforcing exercise, increase hypertrophy, decrease total peritoneum to maximize the cardiac output, or compensatory heart failure, decrease hypertrophy, fluid retention to preload. Basically, we discussed all these examples here. Now, moving towards the uh, pressure volume loops, okay? So, in the case of the pressure volume loops, the remember that we have this whole cycle basically, okay? The cardiac cycle and the pressure volume loops. Now, let's discuss this pressure volume loop. So, here you can see it's a whole cardiac cycle, okay? First, let me tell you how what actually happens within the heart is that first of all, the mitral valve is closed, and when the mitral valve is closed and the isovolumetric contraction is start, basically here the mitral valve is closed, so the blood already in the ventricle and the aortic and mitral valve both are closed. So here now the left ventricle is generating pressure, and the pressure is increasing, increasing, increasing until the left ventricular pressure is more than the aortic pressure, and the aortic valve opens here. So when the aortic valve opens, the blood is ejecting here. The blood start ejected out of the ventricle into the aorta, and during this phase, this is the systolic ejection phase. Now, as the blood is moving out of the aorta, a time will come where the left ventricular pressure again is, you can say, um, is not higher than the aortic pressure. So the aortic valve is closed here. Now, as the aortic valve is closed, then during this third phase, what happened is that the ventricle will relax. So it's also volumetric relaxation start, and it's relaxing, 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 all right, until the mitral valve opens. the blood is passively coming to the heart and is producing this S3. And here the left atrium start contracting, and blood is actively coming to the left ventricle. Again here the mitral valve is closed. So this was basically the whole cycle. The in this phase four, what happened is that we call this rapid filling. Okay, almost like 70%, or you can say more than 70% blood is coming to the left ventricle by passive filling, and the remaining by small amount is by atrial contraction. It's like almost one third. Okay, so two-third is by passive filling, one third is by active filling. So this was about this cardiac cycle. Coming to the sound produced, so S1 is produced, you can say, due to the closure of the mitral and tricuspid valve. We know this. Aortic valve closure, the S2 is produced by the aortic and pulmonary valve closure here. Okay, so these are the sounds. S2 is here, S1 is here, S3 is here, S4 is here. Remember, S4 is when the atrium is contracting against the stiff ventricle. Okay, and S3, you know, it's passive filling. So if you look at this diagram, on the left side they mention the left ventricular pressure, on the right side they mention the uh, left ventricular volume. So normally we have like the systolic blood pressure is, you can say this black is the in a normal person. Okay, this is the normal person curve, the black. So if you look at this uh, volume, the volume here is almost uh, like the pressure is at almost at 80 millimeter of mercury. The as the left ventricular pressure is more than 80 millimeter of mercury, the aortic valve is open. And again here, if you look at here, almost like maybe somewhere near to 100, the aortic valve is closed. So this was like in normal situation. Okay, let's say if you give someone a blood volume, you are increasing the preload. So you are increasing the left ventricular volume, normal volume during the isovolumetric contraction. This was a normal volume. So here what you are doing, you are increasing the preload from this point to this point. This increase in the left ventricular volume occurs. You are increasing the preload. So when you increase the preload, okay, then you are increasing the what? Stroke volume. So normally the stroke volume is like this much. From here to here, this is the left ventricular volume that was ejecting, okay? But here, the stroke volume is increased. It will be like from this area till this area, the stroke volume is increased. Another thing is that if you increase the afterload by giving someone, you can say previously we discussed that how you can increase the uh, afterload. So let's say if you increase the afterload by giving someone vasopressors, okay? So what happened is that normally the aortic valve open here and it ejects the blood. Here, as you can see here, you increase the pressure. So for the left ventricle, to keep the normal stroke volume, it will be generating higher pressure. Okay, so and the end systolic volume will be increased because the by generating the higher pressure by the left ventricle, as you can see here, it will try to overcome this aortic pressure or this resistance, and at the end of the systole the volume remain within the left ventricle will be more. Okay, so normally this was the left ventricle end systolic volume. Here you can see the left ventricle end systolic volume is increased in case of this blue line, this blue after increase after load. Uh, and you can see the stroke volume is reduced. Reduced stroke volume, increased systolic volume, and the aortic pressure is high. Okay, this was the aortic pressure that increased, reached to this. Now, moving towards the contractility. Okay, if you increase the force of contraction by giving someone catecholamines, you are basically, you can see this orange line. You are increasing the stroke volume. You are decreasing the left ventricular and systolic volume. You can see here, and you are uh, you are basically increasing the ejection fraction. So these three situation we compare to the normal. So let's give it. You can say. Let's compare it with the waves. Okay, the CVP waves. Now here in this diagram, you can see this is the left ventricular pressure curve. Okay, this one, left ventricular pressure. This one is the aortic pressure curve. This is the left atrial pressure curve. These are the heart sounds, and these are the CVP lines, and this is the ECG. So first of all, let's first look at this LV pressure curve. Here, the you can see from this area the isovolumetric contraction begins, or you can say the mitral valve is closed here, and the left ventricle start generating pressure, and the left ventricular pressure curve, you can see it's going up, pressure increase, increase, increase. As the pressure within the left ventricle is more than the aortic pressure. This was the aortic line. So it's now the pressure in the LV is more than the aortic pressure. The aortic valve opens here. It will push the aortic valve towards the aorta and the blood starting ejection. So this is the isovolumetric contraction, and here the rapid ejection occurs in this area. Okay, the volume of blood is moving out of the left ventricle, and at this stage, the after this rapid ejection phase, we have this reduced ejection phase. So the blood is going out of the ventricle till this aortic valve is closed. When the aortic valve is closed, then the blood within the aorta is dipping downward over the aortic valve, and it produces this small dip or necrotic notch. So this necrotic notch is because of the closure of the aortic valve. Now you can see the ventricular curve, and the ventricular pressure is decreasing till this is the isovolumetric relaxation phase. And we know that as the aortic valve closes, the pressure within the left ventricle is decreasing. Here, again, the mitral valve is open, and you can see here the passive filling occurs, and again the blood is coming into the left ventricle. So now let's discuss this. Like we know the curve, okay, the CVP curves. First we have the A, then we have the C wave, then we have the X and the Y wave. So because of, as you can see here, as the before the isovolumetric contraction, we have this rapid filling phase and passive filling phase. So whenever the atria is contract, we call it active filling of the left ventricle. So 1/3 of the blood is coming to the left ventricle because of the atrial contraction. And this is because of that atrial contraction producing this A wave. So A waves will generate because of the atrial contraction. Okay. Now after this, the C waves. C wave is produced because of the right ventricular contraction, and when the right ventricle is contract, against the closed tricuspid valve. The closed tricuspid valve is pushed towards the atria. So that pushing of the tricuspid valve towards the atrium is producing this C wave. So remember, C wave is because of the ventricular contraction, and that is causing pushing of the tricuspid valve towards the right atrium. Now this X wave, you can see here, it's basically the X descent. Okay, so this X wave is because of the relaxation. So it's because of what? atrial relaxation. It's a downward displacement that of the tricuspid valve towards the ventricle when the right ventricle is pushed and eject the blood towards the pulmonary valve, and now the cavity of the right ventricle is like empty, so that the tricuspid valve is moving downward towards the right ventricle, and it is producing this X wave. So it is, you can say the X wave is because of the atrial relaxation. Okay. Now, uh, there are certain conditions. I will be discussing this, but just let's move towards this V wave. Now, the V wave is like it is because of the willing or filling. Okay, willing or filling. So it is because of the atrial filling. The atrium is now filled. There's increased atrial pressure due to increased volume against the closed tricuspid valve. Now, as the atrium is filled, this willing or right atrial filling will produce this V wave, and this Y wave is emptying Y, empty Y. So in empty, you can see there is a Y in emptying. So Y wave is because of the emptying of the right atrium into the RV. So it will produce this Y wave. Now, remember, A wave will be absent in case of atrial fibrillation. Okay, it is absent in atrial fibrillation. C wave is absent in case of tricuspid, uh, uh, it will be prominent in case of pulmonary hypertension or in case of tricuspid stenosis. Okay, the C wave. Now, the X wave or the relaxation, here the you can see here this X waves, which was because of the relaxation and downward displacement of tricuspid valve towards the RV. So it is basically absent in case of the tricuspid regurgitation. And in case of the right heart failure, because of the reduced pressure gradient, P waves or the atrial willing or filling, it will be, and you can say it will be, uh, yeah, I think it's also affected in some condition. So this Y wave is absent in case of the cardiac tamponade, okay, or in case of constrict. No, it will be, yeah, it will be absent in cardiac tamponade and will be prominent in constrictive pericarditis, okay, Y wave. Now, this was the ECG curves. You can say the P waves, the QRS complex, and the T waves. It's basically showing the systole, it's showing the relaxation, and P wave is showing the atrial contraction. Atrial relaxation is somewhere disappeared in this area. So, moving towards pressure, volume loops, and in case of these pressure volume loops, there are different conditions where, as you can see here, in case of the aortic stenosis, what happened here? Normally, mitral valve closed, aortic valve open, blood is ejecting into the aorta, aortic valve is closed, and here isovolumetric relaxation, and the passive, here again the mitral valve open, passive filling, active filling, and mitral valve is closed. So isovolumetric contraction, systolic ejection phase, isovolumetric relaxation, passive filling, active filling. So in case of the stiffened aortic valve, aortic stenosis, the valve is open here, but it is stiffened. The amount of blood ejecting from the left ventricle is occurring with the resistance and is not occurring openly. So there will be a resistance to the flow. So the LV has to generate more pressure to overcome the stenosis. That's why it will generate a higher pressure, okay, like almost something somewhere 180 to eject this blood. And still, the blood is not completely out of the left ventricle. So the left ventricular end systolic volume is still high. It is still high. So due to this, first of all, the LV pressure is high, and in order to overcome this aortic stenosis, and second thing, the end systolic volume remain is high in the LV. Okay, so these are the two. And important thing is the stroke volume. Okay, the stroke volume is low in case of aortic stenosis. So you can see here the LV pressure is high, and volume is high, stroke volume is low. But they mentioned that there is no change in the end diastolic volume, because the end diastolic volume is mainly depends on the preload. Okay, so the preload is remain the same, it does not change. And so this was, you can see here that the LV pressure is more than the aortic pressure. It basically shows that the left ventricular pressure is more than the aortic pressure. So as a result of this, we know the law of Laplace, the left ventricular hypertrophy, concentric hypertrophy, it will be decreased ventricular compliance or distensibility, and increase in the end diastolic pressure for a given end diastolic volume. So you can say as a result of the left ventricular hypertrophy, there will be an increase in the end diastolic pressure. This increased end diastolic pressure, we know that the blood supply to the heart is in the diastole. So this increase end diastolic pressure may compromise the blood flow to the heart, and it may cause angina. In case of the aortic regurgitation, you can see here, this was the normal heart. Okay, isovolumetric contraction begins here. Aortic valve opens, aortic valve closes, blood is ejected into the aorta. Now the ventricle is relaxing, mitral valve opens, blood is coming to the left ventricle, and here again the mitral valve is closed. But what happened here is important, is that due to regurgitation, the blood or coming to the, like normally the blood is ejecting from the ventricle into the aorta, but here what happened is that blood is coming back from the aorta into the ventricle, so the volume within the left ventricle will be higher. Okay, now here you can see the blood volume, the left ventricular end diastolic volume is increased because of regurgitation. And here you can see as the mitral valve is closed, isovolumetric relaxation, isovolumetric contraction begins. The aortic valve is open here. So now the blood coming out of the ventricle is more. So the stroke volume is starting from here, it ends here. So the stroke volume is much more higher compared to the normal person. Again, at the end of the, you can say the stroke volume is increased, and the end diastolic volume at the end of diastole, the blood is more. So this is the diastole end here. It's a, so you can see here, normally this is the end diastolic volume till here. And in this patient, somewhere, this is the end diastolic volume. And the dicrotic notch is lost because we know that dicrotic notch is produced because of this aortic valve closure. Here, the aortic valve is not properly closed because of the regurgitation. So the as a result, there is the loss of dicrotic notch. So these three things very important. No true isovolumetric phase, increase in diastolic volume, increase in the stroke volume, and loss of dicrotic notch. In case of mitral stenosis, what happened is the blood coming to the left ventricle is low. Left ventricular, you can say the preload is reduced in case of mitral stenosis, because if there is mitral stenosis, the blood coming from the left ventricle, left atrium to the left ventricle will be low. So we can say the preload is low. Now the preload is low. As a result, there will be a backward pressure in the developed within the left atrium due to the higher volume within the left ventricle atrium, because atrium is not completely emptying into the ventricle. So the LA pressure will be higher. There will be a reduce in the left ventricular end diastolic volume. You can see here, normal end diastolic volume till here, somewhere like 110. Here it will be low. Okay, so you can see here the left ventricular end diastolic volume is low because of the impaired ventricular filling. And when the at the end of the systole, you can see here the systole ends here. So at the end of the systole, uh, the remaining volume of blood within the ventricle is low. So end systolic volume will be low. And the stroke volume will also be low. Why? Because the blood is coming. If you decrease the preload, you are decreasing the stroke volume. We know this concept. Remember these three things, okay? Now coming towards the here, the important thing is the left atrial pressure is more than the left ventricular pressure. Like this, this is the pressure curve, okay? Left atrial pressure curve. So the left atrial pressure curve is this one, and this was the left ventricular pressure. So during this like relaxation phase, diastole, the LA pressure is more than this left ventricular pressure, okay? In case of the mitral regurgitation, as you can see here, uh, mitral regurgitation, blood coming to the left ventricle will be more because of the regurgitation. Left ventricle end diastolic volume is more, and the blood ejecting or the stroke volume coming out of the left ventricle is more, is much more. And the remaining volume of blood within the left ventricle at the end of the systole is lower compared to the normal person. So just remember this diagram is that in regurgitation, both the end diastolic volume and stroke volume is higher, but stroke volume is higher, but the left ventricular systolic volume is reduced. So these are the reasons that why the systolic volume is reduced is because of the decreased resistance and decreased regurgitation into the left atrium during systole. In case of this, you can see here the indostolic volume is higher because of the increased LA volume from the regurgitation and increased ventricular filling. And again, the stroke volume, you can see here that higher the stroke volume is because of the forward flow into the systemic circulation plus the backflow into the LA. So we call this pseudo ejection fraction. Okay. Now, moving towards this splitting of this S2 and this murmurs. So, yes. Let's discuss this waves. Let's say if you put a probe on the patient and you want to record the waveform, let's say if you put the probe or the left side of the chest on the apex, uh, what happened is that during diastole we know that there is passive filling, there is active filling of the left ventricle. Passive filling is because of the when the blood is coming from the left ventricle, from the left atrium ventricle. So during this the passive filling, in which 70% of the blood is coming from the left atrium to the left ventricle, the E wave is produced. Now during the active filling, which is the 30% of the blood coming from the left atrium to the left ventricle, this A wave is produced. Okay, we know that S3 is produced during the passive filling, and S4 sound is produced during the active filling, especially when the atria is contracting against the stiff ventricle. Now, the S1 is somewhere here, which is because of the mitral valve closure. And when the mitral valve is closed, then the isovolumetric contraction occurs. And you can see here that at the area number B, the mid-systolic click can occur here. And S2 heart sound, which is the closure of the aortic valve, occurs here, okay, in the C area. Uh, so if there is like mitral regurgitation, remember, then when the LV is contract, then the waves will be like this. Okay, during systole, as we know that mitral regurgitation occurs, especially when the left ventricle is contract, blood is coming out of the left ventricle, but also the blood is coming out of the left ventricle towards the left atrium, and this wave is produced. Now let's move to the heart like the S2, S1 splitting. Uh, and what are the different conditions? So normally, remember, we have this expiration and inspiration. During the inspiration, there is a negative intrathoracic pressure that sucks the blood from the IVC or SVC and increase the venous return towards the right heart. So the right heart, the right ventricular filling will be more, and the right ventricular stroke volume will be more. So there will be an increased RV ejection time, and there will be a delay of the closure of the pulmonary valve. In simple word, whenever the blood is coming out of the right ventricle towards the pulmonary valve, and this blood is coming more towards the pulmonary valve, taking longer time, then the pulmonary valve will be closed lately, or you can say there will be a delay closure of the pulmonary valve. So decreased pulmonary uh, impedance or increased capacity of the pulmonary circulation also occurs during inspiration, which contributes to the delay closure of the pulmonary valve. Normally, we have the first heart sound, second heart sound. First heart sound is produced because of the mitral valve and tricuspid valve closure. Second heart sound is produced because of the aortic valve and pulmonary valve. So there is two component of the S2, which is A2 and P2. Now, the aortic valve is closed earlier than the pulmonary valve, okay? And like this late closure of the pulmonary valve occurs during the expiration as well as in the inspiration. But during the inspiration, this delay will be more. Normally, the delay between the A2 and P2 is more because during inspiration, blood is coming more towards the right ventricle and it is taking more time to be ejected out of the right ventricle and passing towards the pulmonary valve. That's why when the blood is passing through the pulmonary valve is taking longer time to close. And this closure is produced the P2, so it will be delayed. Now, uh, there are like condition where there is a wide splitting of this P2. Remember, you can see here, S1 heart sound is this one. Now the S2 heart sound, two component A2, P2 during expiration, expiration, A2 and P2 are closer towards each other, but inspiration, the P2 is a little bit delayed. So the delay is normally occur like this. Now, there are certain conditions where the delay is abnormal. It's too much high. Okay, between the A2 and P2, the delay is abnormally high during inspiration as well as expiration. So we call this white splitting. Now, this white splitting is seen in condition that delayed the right ventricular emptying. Obviously, we said that the whenever the blood is coming more towards the right ventricle, so the right ventricle emptying will be occur in a delay manner. The pulmonary valve will close in a delay manner. So this occurs in pulmonary stenosis, right bundle branch block. So that will cause the pulmonary, like the delay in the pulmonic sound, especially on inspiration and exaggeration of the normal splitting. So this is what we call the white splitting. And remember, pulmonary stenosis, the right bundle branch block will cause this. Also, uh, the late P2 will be in pulmonary hypertension. Remember, in pulmonary stenosis, the pulmonary hypertension is like same thing. Why? Because the afterload or the right heart is increased by pulmonary stenosis and by pulmonary hypertension. Now, in case of the like there are conditions where there is fixed splitting. So you can see here, the A2 and P2 is split, but in a fixed manner. Okay, both inspiration and expiration. The closure is you can see here that splitting is fixed. So fixed splitting, atrial septal defect is famous for fixed splitting, and the reason is the left to right shunt. The blood is coming from the left atrium into the right atrium into the right ventricle and is passing through the pulmonary valve. So this blood is coming and is passing in a fixed manner, and there is a fixed splitting of the T2 component. So uh, that's why the pulmonary valve closure will be fixed. Now, there is another condition, which is the paradoxical splitting. In paradoxical splitting, we mean that The normal order is reversed, mean P2 is closing earlier than the A2. And these are the conditions where there is a stenosis of the like aortic valve, or there is a left bundle branch block, or if there is a hypertrophic cardiomyopathy and hypertension. Remember, these are very important conditions. Heard in conditions that delay the aortic valve closure, like aortic stenosis, left bundle branch block, normal order of the sublunar wall. Sublunar wall means the aortic valve and pulmonary valve is reversed, and paradoxical splitting of the P2 occurs before A2. On inspiration, P2 closes later and moves closer to A2, which means that the normal delay which we know on inspiration occurs, that makes the P2 closer to the A2 and eliminating the split. On expiration, the split can be heard opposite to the physiological splitting. You can see here expiration, P2 is here, A2 is here. Inspiration, P2 is close towards the A2. So this means what? This means aortic stenosis, Hookham, left bundle branch block, or hypertension. Now about this S3 and S4 is very important. Remember, in case of the third heart sound, we know it's because of like it's a low pitch early diastolic sound, best heard with the bell at the mitral tricuspid area, and it's because it occurs just after the S2. So obviously, when you close the aortic valve, then there is a sound that is heard, and it it is because of the passive filling of the left ventricle. The blood is coming from the left atrium into the left ventricle as the mitral valve opens. So this basically it coincides with the rapid ventricular filling immediately after opening of the mitral valve or tricuspid valve. So they said that is a reverberant sound. And it could be physiological or pathological. The physiological condition, especially in children, young adults, in case of fever, pregnancy, okay, important, important, important. Children, pregnancy, young adults, fever. Pathologically, in case of after the age of 40, in case of the heart failure, mitral regurg, tricuspid regurg, aortic regurg, ventricular septal defect, heart failure with reduced ejection fraction. So if you look at this S4, it's because of the forceful atrial contraction against the non-compliant or stiff ventricle. Just remember this one line, okay? And S4 occurs when just before the S1, mean the aortic valve, the mitral, before the mitral valve closure. This is the period where the atria or the active filling occurs. So when the atria is contracting against the stiff ventricle, there here the S4 will produce, and just after that S4, you will be hearing the S1. If you like want to make it easy, just remember the diagram of the heart, that cardiac cycle of the isovolumetric contraction, systolic ejection phase, isovolumetric relaxation. Just after the isovolumetric relaxation, remember the S3 was produced here, and it's because of the passive filling, and it was near to the S2, but the active filling was near to the mitral valve closure or S1. Now, moving to the condition, it's always pathological. S4 is always pathological. It's low pitch, soft, vesper, or the mitral tricuspid area. And the causes are the pulmonary stenosis, aortic stenosis, hypertension, heart failure, Hookham. All these conditions lead to stiffening of the left ventricle, or you can say it will lead to the hypertrophy of the left ventricle. So MS and TS causes neither S3 nor S4 because these valve defects cause problem in the atria, while S3, S4 are due to problem in the ventricle. Going toward this area, there are certain conditions. So in the auscultation of the heart, first of all, we have this second intercostal space where the we call this is the aortic area, and we can hear is the systolic murmur. mean the aortic stenosis murmur can be heard in this area, or the flow murmur can be heard in this area. Aortic valve sclerosis murmur, right? So the the aortic uh, regurgitation murmur can be heard in the, you can say, in the this area, which is the left sternal border and third intercostal space. So let's first discuss uh, this aortic pulmonary tricuspid. Then we'll be moving towards the left side murmur. So in the left second intercostal space, this is the aortic stenosis area, aortic area, and we can hear the aortic stenosis murmur, the flow murmur, or aortic valve stenosis murmur. Then we have this left second intercostal space pulmonary area, and we can hear the murmur of the pulmonary stenosis murmur, which is systolic murmur, or the atrial septal defect. The Other than that, the flow murmur, like in pregnancy, like in anemia. Okay. Then we have the tricuspid area and the left sternal border and um, yeah, the third intercostal space. Okay, so in case of the this tricuspid area, this is the left sternal border, third intercostal space, and you can hear here the S1 and S2 as well, and you can hear the systolic murmur of the hypertrophic cardiomyopathy murmur. Okay, diastolic murmur, especially the aortic regurgitation murmur or pulmonary regurgitation murmur, you can hear it in this area. So aortic stenosis murmur is in the right second intercostal space, and aortic regurgitation murmur in the left third intercostal space, where the tricuspid murmur can also be heard, where the hypertrophic obstructive cardiomyopathy murmur can also be heard, and pulmonary regurgitation is the diastolic murmur. In the mitral area, which is this area, this is the fifth intercostal space, mid-clavicular line. Here, the mitral regurgitation murmur, you can hear in this area. And in the fifth intercostal space, mid-clavicular line, you can hear the systolic murmur. You know, the mitral regurgitation murmur is systolic murmur. And the mitral valve prolapse murmur is also systolic murmur. Now, in the diastolic murmur is the mitral stenosis murmur. It can also be heard in this fifth intercostal space, mid-clavicular line, this area. Having said this, we have this the tricuspid area. Okay, so in the tricuspid area, we can hear the holosystolic murmur of the tricuspid regurgitation, the ventricular septal defect murmur, and this is the basically fourth or fifth intercostal space, usually on the left lower stellar border. So this is the area, okay, the fourth or fifth intercostal space, left lower stellar border on the left side. So basically, the VSG murmur is important, and you can hear in this area. The holosystolic murmur of the tricuspid regurgitation can be heard in this area, or the tricuspid stenosis murmur, which is the systolic murmur, diastolic murmur, it can be heard in this area. Overall, just remember the easiest way to remember this systolic and diastolic thing. Mrs. MSD hard S mean Mrs. MRS. MRS mean Mrs. So Mrs. Mitral regurgitation, systolic murmur. MSD, mitral stenosis, diastolic murmur. Hard is silent, so AR, aortic regurgitation, diastolic murmur. Aortic stenosis, systolic murmur. Just remember this, and you'll never forget it. So, other than that, the remember the mitral and pulmonary murmur are same. So, if there is mitral stenosis murmur is diastolic, then the pulmonary stenosis murmur is diastolic. You can see here pulmonary stenosis murmur and systolic ejection murmur. So, and the mitral stenosis and tricuspid are similar murmur. Like we say that mitral stenosis is diastolic murmur, So the tricuspid stenosis is also diastolic murmur. As you can see here, the tricuspid stenosis is diastolic murmur. And same goes for the mitral regurgitation. It's systolic murmur, and tricuspid regurgitation is also, you can say, the systolic or polysystolic murmur. We'll be discussing this by name in the upcoming slide. Just remember these for this area. Now, just remember, in case of the standing or Valsalva, you know, when it's a basically maneuver is performed by a forceful attempt of exhalation against a closed airway, usually, you know, done by closing the mouth or pinching one's nose shut while expelling the air. So, as if blowing up against a balloon. It's like, you know, the straining. So in case of the standing or Valsalva, what you are doing is basically you are decreasing the preload, you are decreasing the LV volume, and you are worsening the murmur of hypertrophic obstructive cardiomyopathy or mitral valve prolapse. It's very important, just remember it. Whenever you decrease the volume of the left V, you are worsening the murmur of Hockham and mitral valve prolapse. On the other side, you are decreasing the flow through the stenotic or regurgitant valve. Mean if the valve is stenosed, if the valve is regurgitant, you are decreasing the flow through these valves. Now, if you look at this, same goes for nitroglycerin. Okay, nitroglycerin decreases the preload, so it will worsen the murmur of Hockham and mitral valve prolapse. In case of the passive leg raise, you are increasing the preload, okay? And when you increase the preload, you are decreasing the Hockham murmur, mitral valve prolapse murmur, but you are increasing the stenotic or regurgitant murmur. Okay, this is opposite. Simple, remember this. Also, in the Valsalva release phase, okay, I will be discussing with you people a chart where I will show you that what actually happens in the Valsalva release phase. So, in case of squatting, in squatting, you are increasing the afterload, you are increasing the preload. So, the murmur that is increased with the squatting is again the stenotic or regurgitant murmur. But the mitral valve prolapse or the Hockham murmur will be decreased with this maneuver. We remember that whenever you are increasing the preload, you are increasing the regurgitant or stenotic murmur. In case of the hand grip, it's increase in afterload. So by hand grip, you are decreasing the stenotic murmur because you are increasing the afterload. So increase reverse flow across the aortic valve. So with the hand grip, you are mostly like the left-sided murmurs, like the aortic regurg, mitral regurg, VSDs, all these murmurs will be increasing. But they said that the aortic stenosis murmur and Hockham murmur will be decreasing. So, in case of the inspiration, inspiration basically you are increasing the venous return towards the heart, and whenever the venous return is increased towards the heart, mean the right side of the heart, so the most of the right side murmur will be increased, and most of the left side murmur will be decreased. This is the main difference. Okay, with inspiration, right side flow is increased, right side murmur is increased, but left side murmur is decreased, and the left flow, also the left side is flow is decreased. So this is the main thing. Okay, on inspiration. Let me and this is basically a Carvalho sign. Okay, this is the whenever the inspiration increase the right side flow, increase the right side murmur, we call it Carvalho sign. Same goes for the left side murmur, which is decreased. In case of, remember, right-sided murmurs increase with inspiration, left-sided murmur increase with expiration. In LEFT, there is E, okay? LE, there is E, so left expiration increase it. In right RI, so inspiration increase the right side murmur. Maneuver effect on the afterload is basically, I will summarize for you people. The backward valve disorder, regurgitation is backward, okay? AR, MR, VSDs. It's usually louder with more afterload. Okay, usually louder with more afterload. But forward valve disease, stenosis, aortic stenosis, mitral stenosis, it is usually softer with the more afterload. It is decreased with the more afterload. Okay, so there's a less pressure difference between the moving blood flow. That's why the murmur becomes softer. And in case of the mitral valve prolapse or hookup, it becomes softer and it increases with the LV cavity. So most murmur increase with more preload except the hookup and mitral valve prolapse. That's the most important point you should remember it. Okay. Now let's move towards the what we call this the Valsalva maneuver chart, and let me show it, the Valsalva maneuver chart. So the Valsalva is basically there is two phases of the Valsalva maneuver, and in one phase, as you can see here, the Valsalva is basically there are two phases of Valsalva. The first phase, in which whenever you close your nostril and you close your like you are basically in a straining position, when you force against the closed nostril and closed glottis, you first of all the pressure will be transmitted to the aorta and the aortic pressure is increased like this, phase number one. Then in case in the second, like this is the first phase we are discussing, this is the strain phase, okay, of the Valsalva. Then there is the relaxation phase of the Valsalva. So in the strain phase of the Valsalva, the point number one is that the force is submitted to the aorta and the aortic pressure is slightly increased. Then as a result, there will be a decrease in the stroke, decrease in the venous return to the right side of the heart or right atrium, and that will lead to the decreased cardiac output, and that is producing this dip. So the blood pressure goes down because right atrial pressure return is decreased, cardiac output is decreased. Now after that, there will be an increase in the what? Increase in the stroke volume due to and heart rate, and it is because it's compensatory. So first transmitted to the aorta, pressure transmitted to the aorta, increase in pressure, then return is reduced, cardiac output is reduced, then the heart rate and stroke volume is increased. Is a compensatory mechanism. Now, when you release the Valsalva or the relaxation phase, first of all, there is the blood surges into the right atrium and pulmonary circulation. So blood is basically coming towards the right atrium and pulmonary circulation, and there is a dip in the blood pressure. Then there is increase in the overall pressure because the increased venous return ejected into the constricted vasculature. Okay, this 4A. And then finally, we have the increased venous tone that return the hemodynamics to the baseline. So just remember this whole chart, it's important. And regarding this Valsalva phase, remember, during the first phase, the heart rate is normal, but when there is a compensating increase in the stroke volume heart rate, which will occur in this area. And also in the relaxation phase, but the return to the normal is because of the vagal tone return. This one, it will decrease the heart rate. So moving towards this, uh, moving towards the, we discussed this Valsalva maneuvers, and right now coming the heart murmur. Okay, so first of all, we have this aortic stenosis murmur, and in the aortic stenosis, we have the murmur of aortic stenosis. You know, whenever the we call this crescendo decrescendo murmur. Basically, crescendo means increase, decrescendo means decrease. So it will be like increasing pattern, then decreasing pattern. Okay, crescendo, decrescendo, aortic stenosis murmur. Now we know that whenever the mitral valve is closed, there is isovolumetric contraction occurs. So when there is isovolumetric contraction started, then a time will come when the aortic valve is open. And when the aortic valve is open, the blood is going out from the left ventricle into the aorta, and then the aortic valve is closed. So when the aortic valve is closed, it produces the A2, S2, sorry. So between the closure of the mitral valve and closure of the aortic valve, during this phase, there'll be a crescendo decrescendo moment. Okay, so it's loudest at the heart base, or you can say in the aortic area, which was the right second costal space, and it radiates to the carotid. It's very important. Okay, aortic stenosis radiates to the carotid area. Soft S2 plus minus ejection click, and there is a pulses parvus at cardus, or the slow rising pulse, or the weak pulse with delayed peak. And usually in older patients, like more than 60 years old patient, most commonly due to age-related calcification, and in younger patient, most commonly due to the early onset of calcification of the bicuspid aortic valve. So there is a stress, hemodynamic stress, and there will be accelerated aging phenomena. So overall, uh, we can say that this is because of the atherosclerosis that can lead to calcification. So the sign will be like the angina, syncope, and dyspnea. These are the three important findings due to the fixed cardiac output. And the LV pressure will be more than the aortic pressure due to the hypertrophy, LV hypertrophy. And the pressure during systole will be like there will be a decrease aortic diastolic blood pressure, increase left ventricular diastolic blood pressure. So overall, this was about the this is what we call this aortic stenosis, and the S2 component. We discussed this. We know that the A2 component of the second heart sound will be delayed. Okay, there will be a delay in the A2 component of the second heart sound. Then we have this mitral tricuspid regurgitation. So the MR or TR is holosystolic high pitch blowing murmur, and like it means that it will be throughout the systole, and mitral regurgitation is basically loudest at the apex because the area for the mitral valve to hurt is the left ventricular 15 costal space, mid-clavicular line on the left side. So it will be loudest at the apex. It will radiate towards the axilla. Mitral regurgitation murmur is radiate towards the axilla. It's very important regarding the MR murmur. Tricuspid regurgitation murmur is loudest at the tricuspid area, and it radiates towards the epigastric area. Okay. Now the MR is often due to like ischemic. It can be ischemic MR. Okay, because of the posterior MI in which the PDA is usually involved, and the or the RCA is involved, and the only blood supply to the posterior medial papillary muscle is either the PDA or the RCA, and this is the reason that due to a single blood supply to his posterior medial papillary muscle, usually these muscles gets infarcted and will lead to the mitral regurgitation. Also, the MR can occur due to the mitral valve prolapse, due to the LV dilatation, or the rheumatic fever. Tricuspid regurgitation is due to the RV dilatation, either MR or TR. It can be because of the infective endocarditis, especially on the right side. IV drug abusers is famous for these tricuspid regurgitation or tricuspid endocarditis. The Yeah, so that's it. Now, if you look at this, uh, let me show you this mitral valve. So this is basically a leaflet of the mitral valve, and in rheumatic endocarditis, myxomatous degeneration, the leaflets can be involved, and the chordae tendineae can rupture due to the rheumatic heart disease, due to endocarditis or myxomatous degeneration. Papillary muscle involvement, especially in the capillary muscle infarct or rupture, or the in case of the uh, LV ischemia or infarction, the displacement of papillary muscle can occur, or dilatation can occur. Mitral endless calcification, especially age-related, or the enlargement is due to the LV dilatation. All these conditions can affect this mitral valve. So mitral valve prolapse, if you look at this S1 and S2, between this S1 and S2, and you can see this whole systolic murmur. So this whole systolic murmur is, when the mitral valve is closed, it produces S1. Now the period started is the isovolumetric contraction, and during this phase, when the ventricle is contracting, the blood is coming out of the ventricle. At the same time, the blood is regurgitating towards the left atrium through the regurgitant wall. So that's why this murmur, the regurgitation murmur, is whole systolic murmur. Okay. Uh, Mitral valve prolapse murmur is like, the crescendo murmur is like, crescendo is like going up. Okay, it's increasing. Crescendo means increasing, and decrescendo means decreasing. So you can see in this, it's the in the late um, systole. So this late systole, this is the systole is begin here till here. So during this, this is a crescendo murmur, but it's a late crescendo murmur. Okay, and here you can see the mid systolic click as well. So it occurs after the carotid pulse, best heard over the apex, and loudest just before the S2. So the important thing in this area is that um, it's usually benign, but it can predispose to infective endocarditis, mitral regurgitation, arrhythmias, and can be caused by rheumatic fever, chordal rupture, or myxomatous degeneration. Can be primary or secondary to connective tissue like Marfan, ADS. It's the most common due to sudden tensing of the chordae tendineae as mitral leaflets prolapse into left atrium. So remember, late crescendo with mid-systolic click is mitral valve prolapse. Moving towards this, what we call this ventricular septal defect, and in the ventricular septal defect, we know the murmur of the VSD is the holosystolic murmur in the left fore intercostal space pastoral area, and we also know that in this murmur there is um, it's usually association with the congenital, because VSD is the common congenital congenital problem, and large VSGs have like the lower intensity murmur than the small VSDs. This is important. The larger the size of the VSD, the lower intensity the murmur is, and small VSD will produce the high intensity murmur. And the most common congenital heart disease, VSD, remember, okay? Usually the defect is in the membranous septum, and it's usually associated with the fetal alcoholic syndrome. So this was regarding this ventricular septal defect. Uh, Now we remember this regarding the aortic stenosis. Uh, Rheumatic heart disease is most common in the developing world. Okay, and it's almost always occurs within the rheumatic mitral valve disease. So mitral involvement in rheumatic cases is higher compared to the aortic. Um, Now, if you look at this diastolic murmurs, we know that aortic regurgitation produces diastolic murmur, and it will be after, as the aortic valve is closed, and during this early diastole, there will be a decrescendo, high pitch blowing murmur, best heard at the base aortic root dilatation or left sternum border in case of the valvular heart disease. So very important, very important. In case of aortic root dilatation, the root problem causing regurgitation, it can be heard on the right side, okay, uh, at the base. And uh, in case of the valvular disease producing the regurgitation, the murmur will be on the left side, okay, left upper sternal border. So late decrescendo, okay, that this is like decreasing intensity, decreasing. So decrescendo. Just after aortic valve closure, the blood will be coming from the aorta into the left ventricle. Normally, when the aortic valve closes, the blood is not coming to the ventricle, but here, as the valve is regurgitated, so the blood is coming after the closure of the aortic valve, S2 is produced, the blood is still coming through the aortic valve into the left atrium, and it's producing the decrescendo heart sound, murmur. And the causes including the aortic regurgitation murmur is the bicuspid aortic valve, endocarditis of the aortic valve, aortic root dilatation, rheumatic fever. Okay, so these were some of the causes. There are certain sign that aortic regurgitation produces bounding and collapsing pulse, which we call it water hammer pulse. Drowsy sign basically a pistol short femoral pulse. Pinky sign is pulsating nail bed. The mustard sign is the head bobbing, um, if severe and chronic. And hyperdynamic dilated LV produces systolic left heart failure. So overall, these are some of the signs that we should remember. Bounding pulse, the rosy signs, quickies, and the muscle. In case of the mitral stenosis, we have this mitral stenosis usually follows the opening snap, and please don't confuse with the opening snap or the mitral stenosis murmur with the you can say the uh, mid-systolic click of the mitral valve prolapse. Okay, so in mitral stenosis we have the opening snap, and opening snap is delayed rumbling, mid to late murmur. Okay, and decreased interval between the S2 and always correlates with increased severity. So uh, basically, the snap observed is created by the stenotic and calcified valve snapping open, or opening snap is produced and is heard during mitral valve opening. So remember, mitral snap is produced during the mitral valve when the mitral valve is open. So this opening will produce a snap. Okay, we call it opening snap (OS). So uh, S2 is followed by the opening snap, and this opening snap and like there will be a delayed mid to late murmur. Late and highly specific sequelae of the rheumatic fever and chronic MS can result in the LA dilatation, pulmonary congestion, antifibrillation, order syndrome, hemoptysis, right heart failure. Remember, whatever this is happening is because of the whenever there is mitral stenosis. Okay, the mitral stenosis produces the backward flow of blood into the left atrium, and that will lead to enlargement of the left atrium, and that is the basis for the uh, atrial fibrillation. Okay, and that will lead to the backward flow of the blood into the LA size increase, atrial fibrillation. The backward flow also the blood moving through the pulmonary vasculature, that will lead to pulmonary congestion. So overall, you can say that LA dilatation, atrial fibrillation, LA dilatation causes compression of the esophagus, Otto syndrome, and pulmonary congestion, pulmonary hypertension can produce hemoptysis. And whenever you increase the pulmonary blood pressure, you are producing pulmonary hypertension on a long term, and you are causing the right heart failure. So, opening in snap is due to abrupt halt in the left leaflet motion in the diastole after rapid opening due to fusion at the leaflet tips. LA pressure is much more than left ventricular pressure in the diastole. It's also, we discussed this previously in a cardiac cycle, that mitral stenosis, LA pressure is higher than LV pressure during diastole. And the opening snap is due to abrupt haltness of the leaflet motion in diastole. So this was about this mitral stenosis murmur. And moving towards remember, there will be no S3 or S4 in the mitral stenosis. Okay, no S3 or S4 in mitral stenosis, because both this S3 and S4 is produced after opening of the mitral valve. Okay, the mitral valve is not easily open in mitral stenosis. The patent ductus arteriosus, remember, continuous machinery like murmur PDA. Okay, throughout the systole and diastole. So this is continuous machinery like murmur, and best heard at the left infraclavicular area, or you can say the interscapular area or the back, and it's loudest at the S2. Um, Often due to it's often due to the congenital rubella or prematurity or combined with the cyanotic congenital heart disease. So this was about this. We discussed this chart previously. In the hypertrophic cardiomyopathy, you can see this crescendo decrescendo murmur at the um, uh, mid left sternal border, and the age receptor defect murmur will be there will be a fixed splitting of the S2. Okay, so just remember this pattern. All right, Hookham murmur is just like aortic stenosis murmur, crescendo decrescendo. Age receptor defect, and it will be a left mid sternal border. Um, In case of the ASD, the murmur is there is a fixed splitting of the S2. Okay, so mean the A2 and P2 split in a fixed split. This point is important for ASD. Moving towards the moving towards this myocardial action potential. Now uh, we have this changes in the membrane voltage of cell, and this change will be transmit the electrical signal formed to the heart and will trigger the contraction of the myocytes. So we have different phases. Okay, in phase 0 there will be a rapid upstroke and depolarization, and it's because of the voltage gated sodium channel, and this will be a phase 0. Okay, because of the voltage gated sodium channel. Now then we have the phase 1 in the initial depolarization phase because of the inactivation of the voltage gated sodium channel, and voltage gated potassium channel begins to open. So this yellow phase is the initial depolarization phase because of the inactivation of sodium channel, because of the voltage gated potassium channel is open. Now this early plateau phase, you can see this phase 2. This plateau, phase 2 is because of the potassium efflux, which is balancing the what? It's balancing the calcium influx. So the calcium is entering into the cell and potassium is exiting from the cell. Voltage gated potassium channel is exiting. So this is balancing each other, is producing this plateau phase. Now during the this calcium influx phase balancing the potassium efflux, this calcium influx triggers calcium release from the sarcoplasmic reticulum and myocyte contraction. So inside contraction coupling. Going towards this phase 3 is the rapid repolarization phase, in which there is a massive potassium efflux due to the opening of the voltage gated slow delayed rectifier of the potassium channel and closure of the voltage gated calcium channel. This phase 3 occurs, and it's the repolarization phase. So delayed rectifier type potassium channel. In the phase 4, this is the resting membrane potential, high potassium permeability throughout the potassium channel in this phase. Okay, and here there will be a delayed rectifier potassium channel. Remember, uh, during this phase, sodium in huge amount, sodium entering into the cell is 0. Then sodium channel close, potassium exiting from the cell. Initial phase 1 of the depolarization. Then in phase 2, calcium is entering, potassium is exiting, blood 2. Then in phase 3, massive amount of potassium exiting from the cell. And in the phase 4, there is a, you can say, permeability from potassium is high during this phase. Okay. So in contrast to the skeletal muscle, um, we can say that cardiac muscle action potential has a plateau phase due to the calcium influx, potassium exit. Cardiac muscle contraction require calcium influx from the extracellular fluid to induce the calcium release from sarcoplasmic reticulum, and the calcium is bound to the ryanodine receptor. We already discussed these. Now the cardiac myocytes are electrically coupled to each other by gap junctions. Okay, and that's how the action potential is spreading. The small ion entry to the gap junction activate the sodium channels of the phase 0. So that's how the action potential is spreading to the nearby cardiac myocytes. Uh, Now let's this basically this type of action potential occurs in the all cardiac myocytes except the SA and the AV node. So what happens in the pacemaker, the SA node or the AV node? Now, in the remember in the this diagram, you can say in this uh, phase zero, what happened is that here in this area, uh, the myocyte nearby myocyte raise the membrane potential via the gap junction, and the rising potential opens the fast sodium channel. So the threshold potential reached about minus 70 millivolt. This thing is important. Okay, so it's basically the threshold is minus 70. Whenever you hit the minus 70 MV millivolt, you are touching the threshold. Large amount of sodium will enter into the cell and rapid depolarization occur at minus 70 millivolt. So remember this minus 70. Okay, and the membrane potential overshoots, and that's how like it will reach to the 0 MV, and fast sodium channels closes. So this is just about the phase 0. Now in phase 2, what happens that the excitation triggers the contraction through excitation-contraction coupling, the sarcoplasmic reticulum mechanism here. And when the action potential depolarizes the cardiac cell, remember the L-type calcium channel is open, allowing the calcium to enter into the cell, and this calcium activates the ryanodine receptors on the sarcoplasmic reticulum. So that causing the large amount of calcium release of the into the cytosol, and that calcium binds to the troponin C, enabling the myosin to interact with the actin and triggers the contraction. Relaxation happens when the calcium is removed from the cytosol. So this is basically the important phenomena we'll discuss with you people in the upcoming slides. Just remember this excitation contraction coupling occurs in the phase 2. Okay, moving towards the this phase pacemaker action potential diagram is very important. And so basically, what's happening is that in the phase 0, remember, this is the upstroke. It's the opening of, just keep this in mind and keep this in mind and know the difference between the myocyte compared to the SAAV nodal action potential. In the phase 0, what happened is there is an upstroke opening of the voltage gated calcium channels, and there is a fast voltage gated sodium channels are permanently inactivated in this phase due to the less negative resting membrane potential of these cells. So slow conduction velocity used by the AV node to prolong the transmission from the atria to the ventricle, and that's how the delay occurred. But regarding this phase 0, uh, is this the upstroke? Okay, calcium channel opens, fast voltage gets inactivate, less negative resting membrane potential, and that will lead to the slow conduction of velocity used by the AV node to prolong this transmission from the atria to the ventricle. Now, in case of this phase 0 followed by this phase 3, in which the repolarization occurs, and it's because of the inactivation of the calcium channel and opening of the potassium channel. Potassium is exiting from the cell, so repolarization. There is no plateau phase 0. Okay, repolarization. And in case of this phase 4, the slow spontaneous diastolic depolarization due to the funny current. Okay, in funny current means that the sodium and potassium is entering and moving out of the cells, and that different from like it will be somehow different from the sodium channel inward. So basically, the slow spontaneous diastolic depolarization, or you can say it's because of the funny current. Uh, Now, if you just remember that the automaticity of the SA and AV node, it's because of basically this phase 4. Okay, so the slope of phase 4 in the SA node, it will determine the heart rate. Okay, this phase will determine the heart rate, and the acetylcholine adenosine decrease the rate of diastolic depolarization and decrease the heart rate, while catecholamines increase the depolarization and increase the heart rate. So it will basically affect in this area. Okay, sympathetic stimulation increase the chance that HCN or the funny current channels are open, and thus increase the heart rate. So in a summary, if you want to like summarize this, remember, automaticity do not require stimulation to initiate the action potential. It's basically means that these nodal areas are capable of self-initiated depolarization and no fast sodium channel activity here. Okay, fewer inward rectifier potassium channel here. Membranous potential never lower than minus 60 millivolt, and the fast sodium channels need like minus 85 millivolt function. Okay, so the overall this was about these uh, difference between the phase 0 or phase 3 and phase 4 of the SA nodal compared to the AV nodal. Okay. Um, Now let's move this toward this ECG, and but one important thing was this minus 60 millivolt compared to this minus 85 millivolt. All right. So remember this as well, that these are the uh, membrane protection and the pacemaker compared to the myocytes. Now moving towards this electrocardiogram. Now, in case of this uh, ECG, remember, SA node can generate 60 to 100 beat uh, per minute or 60 to 100 heart rate. AV node can produce 40 to 60 beat per minute, and his bundle 20 to 40 beat per minute, and the bundle branch is like 20 to 40 beat per minute. Purkinje fiber 25 to 40 beat per minute. Remember, the SA node is the king, okay, because it produces the maximum heart rate, 60 to 100. And if the SA node fails, then the others take over this heart rate function. So, uh, conduction pathway, we have this SA node, follow the SA node generates the heart rate, it's spreading towards the atria, then the AV node, then the bundle his, then the right and left bundle branches, then the Purkinje fibers, and then the ventricles. So the left bundle branches divides into the left anterior and posterior fascicles. SA node is located at the junction of the right atrium and superior vena cava and is a pacemaker inherited dominance with the slow phase of upstroke 600 beat. Where here, okay? This is the SVC, this is the right atrium. So at the junction of the SVC and right atrium, you can see this SA node. Here is bulb, SA node, generating the what? Generating the heart rate 60 to 100 beat. Now, uh, this is the area of the AV node. You can see here. Now, if you look at this AV node, it's located in the posterior, this location is important, posterior inferior part of the integrated septum. Blood supply to the AV node is from the right coronary artery, and the 100 millisecond delay allows the time for ventricular filling. This is very important. The delay in the AV node is important to give the time to the ventricle to fill properly and then to generate the stroke volume. Pacemaker rates normally SA node 60 to 100, followed by the AV node. It's almost 40 to 60, followed by the bundle branches 40 to 25 to 40, followed by the Purkinje and the ventricles with 25 to 40. Now, the speed of conduction is again the speed of conduction in the this Purkinje is much more than the atria, in more than the ventricle, and then the AV node. So this is the speed of the conduction. Purkinje is the conduction speed is higher in the Purkinje compared to the other areas. First of all, remember in the ECG, as you can see here, P wave is because of the atrial depolarization, and the P and R interval is the time to start from the atrial depolarization to the start of the ventricular depolarization. And normally it's 12 to 120 millisecond. You can say less than one big box. The QRS complex is basically is representing the ventricular contraction or ventricular depolarization. That's less than 100 millisecond or less than three small boxes. Uh, if you look at this T wave, or you can say this QT interval, or so the Q and T interval is the T, right? So the QT interval, this QT interval is ventricular repolarization. This is the ventricular depolarization, and this area is the ventricular depolarization, the QT interval. And in this QT interval, uh, is basically showing the ventricular depolarization, mechanical contraction of the ventricles, and ventricular repolarization. Obviously, ventricular depolarization occurs in this QRS complex, ventricular repolarization in this T wave area, and the third thing is the mechanical contraction of the ventricle. So obviously, mechanical contraction of the ventricle simply occurs in the ventricular contraction area. QRS complex. So overall, you can say that QT interval is showing ventricle contraction, ventricle relaxation. T wave is showing the ventricular repolarization, ventricular relaxation, and the T wave inversion may indicate ischemia or recent MI. Yes, obviously, if there is T wave inversion, it shows the old infarct, or you can say here it's mentioned recent MI, all right, and it also means the old infarct, the T wave inversion. J point is basically showing the junction between the end of the QRS complex and start of the ST segment. Where? Here. J point, start of the ST segment. Why important? Because during the ST elevation, if this S and T is elevated above this line, we call this ST elevation MI. Normally, the ST segment is isoelectric. S and T segment is isoelectric. It's on the line. And U wave, normally it's not there, but if there is U wave, it means hypokalemia. U is hypokalemia, and prominent T wave is hyperkalemia. Okay. This was about the ECG. And these are the the SA node, message spread towards the AV node. Then there is the bundle of His right and left bundle branches, and finally we have the anterior and posterior fasciculus. Okay, so besides Purkinje fibers, fast conduction occurs in Purkinje, and then we also this Bachman's triangle. Remember this Bachman's triangle as well. So remember there are certain leads that we placed while recording the ECG. So certain anterior lead, lateral lead, posterior leads, and in order to know these leads, the areas of these leads are important. First of all, we have this V1, which is in the fourth intercostal space to the right side, and then we have the V2, which is the fourth intercostal space on the left side of the sternum, and these both V1, V2 is for the septum. Okay. Then we have the V3, which is between the V2 and V4. Okay, V3 is between the V2 and V4, and V4 is in the fifth intercostal space on the left midclavicular line. This area, the apex area, basically of the heart. Then the V5 is between the level with the V4 and its left anterior axillary line. This one, okay. So it's the left anterior axillary line, and the mid axillary line is V6. Now in the axilla, we have the anterior axillary line, mid axillary line, posterior axillary line. So on the anterior axillary line, we have this V5, and on the mid axillary line, we have the V6. Remember, V1, V2 is for the septum, 3 and 4 is for the anterior, we call this anterior lead for the anterior heart, 5 and 6 for the lateral leads. We call this lateral lead because it's viewing the heart from the lateral side, or it's recording the electric activity on the left side laterally. Now, if you look at the V7, V7 is basically the left posterior axillary line. So anterior axillary line V5, mid axillary line V6, posterior axillary line V7, but posterior axillary line we will be like we were saying is a posterior lead, okay? Then the tip of the left scapula, you can say this is the left scapula and it's the tip of the left scapula. Here will be V8. And the left parasternal region, this area, here it will be V9, okay? So just remember this sequence to put the ECG leads on the patient while recording the ECG. Now coming towards the atrial natriuretic peptides, basically we call this A and P and the B and P. So ANP is released from the atrial myocyte in response to increased blood volume and atrial pressure. It acts via the CGMP and it causes the vasodilation and decreases the sodium reabsorption at the renal collecting tubule. It dilates the afferent renal arterioles, okay, and it will doing what? It will be causing the constricts the efferent arterioles, promoting the diuresis, contributing to aldosterone escape mechanism. Now, very important, whenever the blood pressure or the blood volume is increased, then the atrial pressure will be increased. So the atrial myocyte will release this atrial natriuretic peptide, and it will be trying to reduce the volume by causing its diuretic effect. How? It causes like the vasodilation by CGMP. But remember, the CGMP is normally for the vasodilation. Okay, nitric oxide also causing this CGMP pathway causes vasodilation. So basically, the atrial myocyte causes vasodilation, and it decreases the sodium reabsorption. So this is basically the diuretic effect at the renal collecting tubule. It dilates the afferent arteriole, more blood is coming towards the kidney, and it will constrict the afferent arteriole to give more time to the kidney to excrete what? To excrete this uh, to improve to increase the diuresis basically. So when you decrease the reabsorption of sodium, you are basically excreting the sodium. So when you excrete the sodium, it's a osmotically active particle, it will draw the water. When you draw the water, it decreases the volume of the blood. So overall, this is basically promoting the diuresis. We call this aldosterone escape mechanism. The BNP is basically the it's released from the ventricular myocytes in response to increased tension, and it's similar physiological action to the ANP with a longer half-life. BNP blood test used for diagnostic of the heart failure. Obviously, whenever there is heart failure, there is increased volume of blood or increased pressure on the LV muscles, LV myocytes, and these myocytes will release the BNP, and the BNP is doing the same function. Like it will be causing this vasodilatory effect, it will be causing its diuretic effects. So BNP blood test is usually we do it for the heart failure. It's very good. If it's negative, it will it will give us a prediction about the heart failure, that the heart failure is ruled out. So low value is ruled out the heart failure. Regarding this baroreceptors and the chemoreceptors, um, this diagram will like the main diagram, and look at these receptors. Remember, the aortic arch is the arch of aorta, and here in the aortic arch we have this aortic baroreceptors. So the baroreceptors, especially when there is decrease in the blood pressure, then we decrease arterial pressure, then we decrease stretch, and the afferent baroreceptors. Okay, the afferent baroreceptors will fire, and increase in the sympathetic firing and decrease in the efferent parasympathetic stimulation will increase the heart and blood pressure. Overall, remember, uh, this is the uh, solitarius nucleus, structure solitarius nucleus, and of the medulla. And in the afferent pathway, you can see here the glossopharyngeal nerve. Okay, so the glossopharyngeal nerve carrying the message from the carotid sinus and aortic arch or aortic chemoreceptors through this afferent pathway. It will move to the solitary nucleus, and from the solitary nucleus, the efferent pathway will be from this area, okay, on the medulla, and it will stimulate the sympathetic nervous system. Now, aortic arch transmit via the vagus nerve to solitary nucleus of the medulla. It will respond to change in the blood pressure. So the carotid sinus, which is this area, okay, the carotid sinus dilated region superior to the bifurcation of the carotid artery. This is the carotid artery. This is the bifurcation of carotid artery. So here, just above this area is the carotid sinus. It will transmit the message from here via the glossopharyngeal nerve to the tectosolitos nucleus of the medulla, and it will respond to changes in the blood pressure. The chemoreceptor, these are the peripheral carotid and aortic bodies. You can see here is the carotid body, and here it's the aortic chemoreceptor. So here the chemoreceptors carrying the message of the PCO2 level. So basically, it is detecting the pH of the blood by detecting the PCO2 level. If the pH is low, if the PCO2 level is more, if there is reduced PO2, so it will stimulate this chemoreceptor, and that will go and send the message uh, to the via the vagus nerve, and the message carries, and it will tell the respiratory center to increase the respiratory rate. So when you increase the respiratory rate increase, the CO2 will be blown out. Okay, so uh, that's how the central, we have peripheral chemoreceptor, central chemoreceptor. Peripheral chemoreceptor is which one? It's the carotid and aortic body are stimulated by the increased partial pressure of carbon dioxide or reduced pH of the blood and or decreased pressure of the oxygen. The central chemoreceptors are stimulated by a change in pH and partial pressure of carbon dioxide of the brain interstitial fluid, and which in turn are influenced by the arterial CO2 level, as like hydrogen ion cannot cross the blood-brain barrier. So basically, for the central chemoreceptor, the trigger is what? PCO2 level, arterial CO2 level. Okay. Do not directly respond to PO2 or hydrogen ion, because these hydrogen ion cannot cross the blood-brain barrier, and the PO2 cannot, like, it will not respond to the partial pressure of oxygen. Central chemoreceptor becomes less responsive with the chronically increased partial pressure of carbon dioxide, increased dependence on peripheral chemoreceptors to detect the low O2 to drive the respiration. So let's say if someone is having uh, someone is like is having increased partial pressure of carbon dioxide, then this will be picked up by this peripheral chemoreceptor, and it will be giving the message to the peripheral chemoreceptor, will giving a message to the respiratory center in the medulla and telling to increase the respiratory rate, to increase the blow of the CO2. So that's how it will, like during the acidosis, our our central our respiratory center respond to the acidosis by increasing the respiratory rate. Now the baroreceptors respond to the hypotension, and it's basically presents over this aortic arch. And whenever there is decrease in the arterial pressure, there is an increased stretch over this baroreceptors, and the afferent baroreceptors will fire through the vagus nerve, okay, this vagus nerve, and it will be telling to, like, the message will go to the this tectosolitorius nucleus, and that will then stimulate the efferent sympathetic firing and decrease the efferent parasympathetic stimulation. So overall, the sympathetic fire will increase. There will be peripheral vasoconstriction. There will be increase in heart rate. There will be increase in contractility. So the blood pressure improves. And this is very important during the hypovolemic shock. Okay, this because when the volume is low, then this whole phenomenon will occur. Remember, whenever we massage the carotid area, we are basically increasing the pressure over this carotid sinus, baroreceptor. Whenever you see the baroreceptor, we are talking about the pressure, okay, blood pressure mechanism, control of the blood pressure. Remember, baroreceptor. So carotid sinus baroreceptor, when you stimulate the carotid sinus, you are increasing the pressure over the baroreceptor, and you are telling the baroreceptor that the blood pressure is increased. So whenever you stimulate the baroreceptor by carotid massage, you are telling to the tractus solitarius via the vagus glossopharyngeal nerve that the blood pressure is high and stimulate the parasympathetic pathway. So the parasympathetic stimulation will lead to the decrease in the like it will decrease the stimulation of the SNA. We know via the parasympathetic stimulation. We know the parasympathetic decrease the heart rate by the SA node and AV node, decreasing the AV node and SA node rate. So uh, again, carotid massage increase carotid sinus pressure, increase afferent baroreceptor firing, increase AV node refractory period. Whenever you increase the AV node refractory period, you are increasing the delay between the ATR to the ventricle and decreasing the heart rate, decreasing the cardiac output. Also, it will lead to peripheral vasodilation because you know the parasympathetic will cause vasodilation. Okay, so it can cause the pre-syncope, syncope, exaggerated in the underlying atherosclerosis, prior neck surgery, older age, and it's a component of the Cushing reflex triad like hypertension, bradycardia, respiratory depression. You know, it's a Cushing reflex. Whenever there is increase in intracranial pressure, that will lead to the compensatory Cushing reflex activation, in which there will be bradycardia, hypertension, and respiratory depression. Usually, the increase in intracranial pressure constricts the arterioles, cerebral edema, increased body pressure of carbon dioxide, and reducing the pH. The central reflex sympathetic increase in the peritoneal pressure and increase in the stretch peripheral reflex receptor. So this is basically a reflux mechanism. In the CNS, we will discuss in detail. For now, just remember these three mechanisms, okay? After that, uh, uh, normal resting cardiac pressures. In the normal resting condition, pulmonary capillary wedge pressure in millimeter of mercury is a good approximation of the left atrial pressure, except in case of the mitral stenosis, where the pulmonary capillary wedge pressure will be more than the left ventricular pressure or the left ventricular end diastolic pressure. Pulmonary capillary wedge pressure is measured with the pulmonary artery catheter or Swan-Ganz catheter. Simply, this means if you put a catheter within the pulmonary artery, it will indirectly tell you the left atrial pressure. Okay, that is the best approximation of the left atrial pressure. But this rule is not applying in case of the mitral stenosis, because in case of the mitral stenosis, the pulmonary capillary wedge pressure will be more than the left ventricular end diastolic pressure, because it's the pulmonary capillary wedge pressure in simple wordings. If you stenose the mitral valve, the pulmonary capillary wedge pressure is increased. And we know this pressure by Swan-Ganz catheter. In case of the auto-regulation, remember this normal pressure, okay? Normally, we said that the right atrial pressure is 5 millimeter of mercury, and the right ventricular pressure is like it's 25 by 25 is the systolic and 5 is the diastolic. The LA pressure is 10, or you can say here they mention is like less than 12. In case of the left ventricular pressure, remember 120 by 12 or less than 12, and aortic pressure is 120 by 80. These pressures are important. Remember the pulmonary arterial pressure or the PA pressure is the 25 by 8. There is a range, and I think the range is important. Moving towards the auto regulation, the simple way is 5 in RA, 10 in LA, 25 in the RV, 120 in the LV by 10, or here they mentioned less than 12, and 120 by 80 is the aorta. And here they mentioned is the 25 by 8. Autoregulation, how the blood flow to an organ remains constant over a wide range of perfusion fashion. So in case of the, in case of the heart, the local metabolites, like it's the factor that determine the autoregulation, and that includes nitric oxides, carbon dioxide, reduced oxygen, adenosine. What did this mean? This means that whenever you reduce the blood flow to the heart, like there is ischemic heart disease, coronary occlusion, so the blood flow to the myocyte is low. Here, the local metabolites will release, adenosine will release, um, there will be an acidosis, so CO2 will be high. The oxygen will be low in that area. So nitric oxide will release. So all these metabolites will try to vasodilate and try to increase the blood flow to the myocytes. In case of the lungs, whenever you decrease the oxygen to the alveoli, in these areas there will be a alveolar constriction, like there will be a alveolar vasoconstriction to that area. So if you reduce the oxygen to the lungs, in that portion of the lung, there will be a vasoconstriction. So the blood will be diverted towards the more perfused area, towards the more oxygenated area. That's how the lungs are auto-regulating its blood supply. So the brain is basically, there is a myogenic or local metabolite regulatory response, which is because of the CO2. Let's say if there is an increase in the intracranial pressure, so that increase in intracranial pressure will lead to increase in the CO2. The pH will be high, and that increased pH will lead to the vasodilation. Remember this. Just remember this, that increased CO2 causes increase in the vasodilation for the brain. Okay, so raised intracranial pressure will cause, like this will lead to increased CO2, will lead to increased vasodilation. In case of the kidneys, it's a myogenic response, a stretch reflex of the efferent arteriole and tubuloglomerular feedback. We will be discussing this in the kidney, but for the time being, just remember that this response is basically occurred by the blood pressure and the sodium chloride feedback mechanism. Then we have this skeletal muscle response, and the skeletal muscle response, like let's say there is someone is doing an exercise, so the skeletal muscle needs more blood supply. Okay, so there will be a local metabolite like carbon dioxide, hydrogen ion, adenosine, lactate, potassium. Overall, it will increase the vasodilation to the skeletal muscles. And in case, like at rest sympathetic tone in arteries, norepinephrine, epinephrine, that will cause, that will improve the blood flow to these skeletal muscles. In case of this skin, it is sympathetic vasoconstriction most important, like mechanism for temperature control. Where there is cold, it will lead to vasoconstriction to reduce the heat loss. And whenever there is heat outside, like there is a dilation, and to lead to like so in order to reduce the body temperature. So you can see here the tubuloglomerular feedback mechanism in case of the kidney. Increase arterial blood pressure, increase driving pressure into the glomerulus, increase glomerular capillary pressure, increase glomerular filtrate, increase rate of fluid through the tubules, stimulation of the macula densa to release what? Vasoactive chemicals. Now these vasoactive chemicals induce the afferent arterial vasoconstriction, ATP, adenosine, and the decrease in blood flow into the glomerulus, decrease glomerular capillary pressure to normal and decrease GFR to normal. So that's how the tubuloglomerular response occurs. The detail, we will be discussing this in a more conceptual manner in the renal chapter. Capillary fluid exchange. Now, we have this stalling force that will determine the fluid movement through the capillary membrane. Remember, capillary hydrostatic pressure pushing the fluid out of the capillaries, and the capillary oncotic pressure keeping the fluid within the capillaries. So these oncotic and hydrostatic pressure are the two pressures that is working against each other. In case of the capillary hydrostatic pressure, it pushes the fluid out of the capillary. It's just like a water, okay? It's the water pressure that is pushing like to move the fluid out of the capillaries. And within the interstitium, there is a hydrostatic pressure which is pushing the hydrostatic fluid towards the capillaries. So these two push is working against each other. Now another oncotic or the protein pressure that is keeping the fluid with itself. So it pulls basically the fluid into the capillaries. The capillary oncotic pressure pulls the fluid into the capillaries, while the hydrostatic oncotic pressure pulls the fluid into the interstitial area. Now, like the net force will decide that either the fluid will move out of the capillary or the fluid will move into the capillaries. So there is this, you can say this equation. Net fluid flow is basically the capillary permeability, which is different for toxin, infection, burn, etc. Pulmonary, what we call is hydrostatic pressure of the capillaries minus the interstitial hydrostatic pressure, and then we oncotic capillary pressure minus oncotic interstitial pressure, and the final pressure will tell us that where the fluid will be going. So this was about this. If you look at this, let me show you some diagram. I hope it will, or we can discuss even this diagram. So basically, in case of this, you can see here the filtration and the absorption. The absorption means net flow into the capillaries. Filtration means net flow out of the capillaries. And this is the blood capillaries, okay, or arteriole, and this is the interstitium. So these fluids pushing against each other, working against each other, and trying to keep the balance. Okay, the balance is important. So this was about the physiology of the heart. Now we will be discussing the pathology of the cardiovascular system.